So, um, I wish I could see all of you guys. You have the advantage, hopefully, of seeing me and hearing me. And so, thank you for your time, whether it's this evening, if you're in Europe, as I see some of you are, and some familiar names and faces here. If you're in the across the water over in Canada or the States, I guess this is lunchtime or even morning time for you guys. So, thank you for spending some time with me for what is an interesting hour or so where you can interact a little bit. If you want to ask any questions, then by all means post in chat. But let me introduce myself just to begin with. I'm an optometrist of advancing years, so 30 years worth of practice, but I've been involved in private optometric practice as a contact lens specialist and a dry eye specialist. I've also worked in ophthalmology settings and more recently worked together with 12 ophthalmologists in one of the largest private independent ophthalmology practices here in the UK. And as a fool, I set up a new venture together with an ophthalmologist where we have an MD, OD, an optometrist and ophthalmology practice, combining the two specialities. So that is my background, and I'd just like to share with you a little bit about what the dry eye practice is and what it looks like in 2020 for me. I confess that I'm a little bit obsessive when it comes to some of the technology and providing the best possible care for my patients. So I'll run through this. I've been very honored to be awarded various gongs over the years in terms of some of my work. And I am also an honorary lecturer at the University of Cardiff here in the UK. So bear with me, and if you do want to add anything to a chat, I'll try and answer those questions as we go along. So what does a dry eye practice mean and look like today? Well, first of all, it's a great opportunity. Dry eye ocular surface is becoming very topical. We've seen the American Academy involving dry eye assessments with all intraocular lens surgery. We've known for a long time that the ocular surface not only gives us opportunities in improving comfort for patients, but also their quality of vision as well, whether this is a contact lens patient, a refractive surgery patient, or also things like glaucoma patients that inherently have, certainly here in the UK, where we still use preservatives in some of our drops, we induce some dry eye conditions. So it's a great opportunity, really, both as from an optometric point of view and an ophthalmology point of view. But let's ask some questions. What are those opportunities? And so the questions I will ask you to ask yourself is, what sort of percentage of patients in your clinics really suffer from dry eye? How much of an impact does this have on a patient's quality of life? And what have we learned over the last few years in terms of dry eyes and how we can improve the care for our patients? So the first of those questions was, what percentage of patients actually suffer from dry eye? Depending on your definition of dry eye, it may be anything from 40, 50, up to 80, 90% of patients. So it's a great big market. It's an opportunity to engage with patients and really overcome some of their problems. You notice the word there, people suffer from dry eyes, and they do suffer from dry eyes. And that leads to the next question that I have, which is, how much of an impact does this have on a person's quality of life? So for me, okay, I might see some of the more advanced and severe cases of dry eye. I've had patients that have turned around to me and said, they're suicidal because they have this constant pain and irritation. I've even had patients who have turned around and said, can you remove the eye because it's just intolerable. But those are the very severe cases. But we need to know what's going on. On a more regular basis, there's a lot of dry eye associated with the new environment we have, the screen technology that we are involved with ever more as time goes on. but also the environment where we are in air conditioning or air controlled environments. We're getting a lot more dry eye and seeing dry eye in young patients as well. So teenagers with dry eye because they're not blinking as frequently because they're always staring at their mobile phone, and that changes the blink dynamics. So we like metrics, and certainly I like metrics. Within clinical situations, we like metrics. There is an answer to the question of how much of an impact dry eye has on a quality of life. And various papers have looked at this and created what's called a utility assessment, not specifically for dry eye, but other conditions that might affect patients in general. So a dry eye score gives us an indication of 0.56, and that's a numeric value. And this was assigned a numeric value based on the fact that the studies requested the patient say, how many of your years of life would you give away to overcome your condition? So if you had severe angina, chest pain that was interfering with you doing things on a day-to-day basis, or you have renal dialysis where you have to go into hospital or a medical setting to undertake the dialysis, that's impacting on quality of life. And in actual fact, the dry eye score was very similar to both of those. If we have a mild dry eye, it's like having mild angina. With dry eye, you would put drops in the eyes, potentially. With angina, you might put a tablet underneath your tongue, and that would be a simple solution. It may interfere a little bit with your life, but not a great deal. But then we have severe dry eye that stops people going out. It stops them doing various things, very much in the same way as severe angina can stop people in their tracks. So I've had patients that say, yeah, it's something that I want to get rid of. And I've not been frightened sometimes to ask a patient when I've had a student alongside me, how much would you value, how much would you give me, or would you spend to overcome this problem? And that's an interesting question. Some of these patients will say a couple of £1,000, so I'm not sure where the pound is relative to the euro or the various currencies, but it's a significant amount of money. And it's something that we have to get a grasp of. In actual fact, sometimes patients suffer on their own, and our profession has been, or professions have been somewhat abdicating responsibility and not taking on board the impact the dry eye has. It's something that affects a lot of people, and it affects them in a very significant way, perhaps even causing anxiety and depression in a lot of these patients. So it is a serious condition, and it's something that we really should be looking at. So what is new? I guess a lot of you, looking at the people who are joining and those that I recognize, you're familiar with what is the GEWS2 report, which was a 1,000 referenced paper which looked at dry eye a couple of years ago, so just 2 years ago. It came out with the longest sentence I'm familiar with in the English language, and I'll just highlight a couple of things here. So it's characterized by loss of homeostasis. This is saying something has disrupted the nature of the biological system which we have, so our bodies. It causes symptoms, and it's associated with tear film instability and hyper-osmolarity, and it causes inflammation or inflammation of the ocular surface. So those are some of the key words, and we'll look at those in a little bit more detail. But being a man, and yes, I have read the whole, from word one to the very last word, many, many thousands of words. I've read this whole paper, but as a man, we like to follow instructions which are almost as a diagrammatic process. In this case, we look at GEWS2 and they provide us with a patient flow. What should we be doing as a blueprint, as a possible guideline rather than a protocol? What should we be doing? And if we work from the left of the screen here, we naturally ask with our history and symptoms, triaging questions. This might be medication, it may be the environment. We might look at actually specifically asking about risk factors such as smoking, any contact lens wear, because we have to remind ourselves that contact lenses can induce some dryness of the eyes. Corneal laser surgery certainly will induce some dryness of the eyes, and I'm guilty here. I've been involved both in fitting a lot of patients with contact lenses, and also as a director of a corneal laser company, I've probably induced more dry eye than I've ever solved. But this is me coming to the table and saying, well, what can we do with these patients? But JUICE 2 comes up with the concept, a platform of diagnostic tests. So in the center blue area here, we can see that we have a screening and those homeostatic markers. And effectively, JUICE 2 says to have a diagnosed dry eye, you have to have symptoms. Then you have to have one of the three of the homeostatic markers. In actual fact, I would like as many markers as possible to indicate and to improve the specificity and sensitivity of any diagnosis. So we start with symptomology, then we go through some of the tests we may routinely do in clinic, or some of them may be a little bit more advanced. And then we go through to the differential diagnosis. What sort of dry eye is it? Because we all understand that dry eye is a multifactorial condition. Okay, so it's a lot of things coming together. And actually no two patients have that identical dry eye. We naturally like to pigeonhole what patients are. But in this case, they are probably evaporative dry eye and have an aqueous deficiency as well, to some degree. Are there pure evaporative dry eye patients? For sure, there may be. There may be aqueous deficient dry eye patients, yes, but very often there will be a blending of that, and we can see with the diagram here that grading between the two extremes. But let's run through and see what our diagnostics tests are and how we can come to a true diagnosis with regard to the ocular surface condition and the part that is played by the tear production and the tear quality. So breaking the JUICE 2 report up, we can look at, first of all, symptomology. Now, I'm not sure how many of you do have a questionnaire in clinic. The most well-known and probably the most researched and used in research dry eye questionnaire is the OSDI. So this is where very often we start. There are other simpler, more straightforward and shorter versions such as the DEQ5 or the speed test, which is something that we can just simply leave out in the reception area for patients to fill out. It takes less than 2 minutes, and then we come up with a number, a metric, in terms of the degree of dry eye that patient might have, or a yes, it's dry, or no. So it gives us an understanding of what the dry eye experience is for the patient. So that's the symptomology. If we're doing this, we'd like to record that. So in the platform that I'm going to talk to you about today, which is the IDRA platform, which is the go-to for me in terms of diagnosis and really categorizing dry eye, the IDRA actually has within the software a dry eye questionnaire very similar and akin to the OSDI and well validated. But let's have a look. So we have a patient potentially with symptoms, and we can record a numeric value to those symptoms. Then we need to run through these other tests. We can see at the very top here, there's what's called a non-invasive tear breakup time. And in brackets, it says fluorescein. Well, we know that actually by placing any drops in the eyes or fluorescein within the eye, that would disrupt the tear dynamics and the tear quality, and so may interfere with various metrics we want to look at in terms of ocular surface. So we have the tear breakup time. We have osmolarity, and then we look at surface staining. So let's go one at a time here. I guess most of you will currently do a tear breakup time. If you're doing it with fluorescein, I think we should understand that we need to move into a non-invasive. So we're looking at the natural tears and how they bathe the cornea and the conjunctiva. So we can do this historically with things such as topographers. But in actual fact, if we use this technology and create an algorithm to analyze the breakup of those circles or the image from the corneal surface or the tear film surface, because in actual fact, that's what we're looking at in terms of the reflections. It's not the corneal shape, it's actually the shape on that very front surface of the tears. So instead of just looking at an image and trying to ascertain when we see some of the breakup, we can actually use computer algorithms to show when the first area zone breaks up, the location of that zone, and the degree of breakup. So in this case, we have a breakup of the tear film, which is occurring along a stepwise fashion on the bottom of the screen here. And we're actually getting a breakup here initially around about 3 to 4 seconds, and then it continues to break up, increasingly break up over the course of the next 4 or 5 seconds. So in this case, we could say that the breakup being prior to 10 seconds is a positive diagnosis of dry eye. But more so, if we can grade that, we can see in the lower area here a traffic light system. So I think this is great in terms of understanding if you're not a dry eye specialist or ocular surface specialist, or if you're a patient, they very well understand the fact that the red is probably stopped. We need to do something. There's an issue. There's an amber or yellow, and green is okay. So one of the key features that I feel is a major step forward with some of the technologies, such as the IDRA technology for SBM, is that it informs patients of what the condition is. And it not only informs them, it gives them a real-time evaluation of their own eye, rather than just a specific symptom giving rise to a specific sign. They can see that happening in real time whilst they're there. And just moving to one side, in actual fact, I have a confession here that my technician does more of the evaluation and the background of the dry eye than I do. My technician or nurse is very adept at undertaking the series of evaluations with IDRA to create a portfolio, a dashboard of diagnostic features that then they can provide to me in the clinical setting. When I'm looking on a slit lamp, I actually have the whole diagnostic platform available to me. And in some ways, the patients have been pre-diagnosed or advised of what the condition may be. They've seen the fact that the tears are breaking up, and they understand that. So in this case, if we're saying that tears break up after 3 or 4 seconds, we'd expect a blink frequency to be a little bit along the same lines. So that's a key message here, is have a platform that we can show the patients what the condition of their eyes are. Very often we've got patients with dry eye that really feel as if they haven't been listened to before. Very often they would come in and they'll say, oh, I bought this product off the internet or that product off the internet or the pharmacy, and they've been getting nowhere. No one's really listened to them and taken this seriously. By showing patients the condition of their eyes and being scientific in evaluating them, they understand that we're taking them seriously. They also can share this information with their friends and family. So let's have a look at another image here. So we have an image here, and you can see the circles there are breaking up somewhat. And along the bottom line here, we have the traffic light system once more. And we can see there's one marker in the red here, which is after 3 seconds, coming up to 7 seconds. So the first breakup being around about 3 seconds, and significant breakup of the tears after 7 seconds. So this would be evaluated and scored accordingly. Now, why is it important to create those numbers? We've seen in terms of patients' appreciation and adoption of various medical strategies that actually giving them a number at the beginning. So let's say a patient has systemic hypertension. They would naturally expect you to measure their blood pressure when they come in to see you. And then after a period of treatment, they would want that blood pressure to be seen to be coming down. If they see that being effective, then we know then their commitment to that therapy regime is going to be very much greater. So numbers are important. And one of the numbers we have historically had is something which is the tear osmolarity. Tear film osmolarity has split the professions here somewhat. I am an advocate of osmolarity, but it does give us a number and one of the diagnostic tests, but I don't think it's the only test or a core test that we must have. It's something that can be put into the software that we use with the SBM Systemi technology, so we can import that to give us a platform and a portfolio of treatments. But it's something that it's nice to have. It's something that patients like because it gives a number. What it does describe is the way in which the saltiness of the tears build up as the water from the tears evaporates. So it's a diagnosis of that evaporative dry eye, and it impacts on various epithelial cells and also goblet cells, and it creates damage to those cells, apoptosis, and creates, as we understand it, and we've heard all too often, is this cycle of dry eye. Well, if we want and understand the dry eye, and the core mechanism of being dry eye is the instability of the tears, we need to get some metrics around the stability of the tears and the structure of the tears itself. This is a simple diagram that you've no doubt seen before, which looks at tear film instability on the right, causing an increased saltiness of the tears, activating and controlling an inflammatory cascade, which causes apoptosis and cell death, which then further initiates an instability of the tears. So we need to understand how we can break that cycle of dry eye. Two things here. That image, that circle on the right says tear film. Yes, we need to analyze the tear film and also the stability. Okay, so stability is important. The stability has a function of time as well. So we know that the tears will blink, the eyes will blink and spread the tears over the corneal surface, and that's in a very dynamic way. So we've got to look at what happens between the blinks as well as immediately before or after the blink itself. So one thing that I don't have slides here for, but actually the IDRA has a blink dynamics. It has a way of analyzing a complete blink or partial blink. And this is really important to me, more especially with the advent of greater computer or computerized displays where the blink rate reduces or there's an incomplete blink. It's almost as if we're finding that we don't have time in today's world for the lid to come down and collide with the bottom lid. And it's that drawing up of the meibum and the separation of the two lids that actually draws the meibum, the meibomium fluid, out of the meibomium glands. If we're not getting that flushing of the meibomium glands, we're going to get some breakup in terms of the tear film stability. Okay. So we have a couple of late starters here, but I'll give a very quick overview towards the end here. We all perhaps have the option of grading scales. We know that on a slit lamp we can use fluorescein. So if we've undertaken all the non-invasive tests that we can do, we can then instill fluorescein or some other vital dyes. and this will give us a staining pattern. I think in today's world, if you've not got a digital slit lamp, it is important to get something where an image can be taken and stored. In this case, the IDRA offers an opportunity to replace or to give a digital image in terms of the lids, the conjunctival redness, but also corneal staining here. So it's a nice adjunct to your normal optometric or ophthalmology practice, something that we can do, and it helps to describe to patients what the conditions are that the eyes are. So let's come back to the JUICE 2 report. So we've gone through this. We've got a patient who's suffering symptoms, and they have one or two of these other situations: a non-invasive tear breakup time of under 10 seconds, saltiness of the tears, an osmolarity that is greater to or equal to 308, with a disparity of greater than 8 millimeters if they have a low osmolarity, and they have some staining. So we have a positive diagnosis of dry eye. Then we want to know what sort of dry eye it is and what the likely cause of the dry eye is, so that we can target the treatment. If we don't target the treatment, we can be ineffective and patients can be lost to follow-up because they're not seeing any benefits. Okay. I'm going to just take a very short break here. There's a question come in that this is from Francis Roy. The question is, you said in the beginning that dry eye disease patients all have symptoms. This has not been my experience when you screen all patients preoperatively. I concur. Okay, I agree with that. We get some patients, especially if they have neurotrophic problems, so something's happened, excuse me, to the corneal nerves, where they're not getting any sensation. So some patients do have an ocular surface breakup, anomaly, so they do have a dry eye without having symptoms. The reason I said dry eye patients have symptoms is the classification to which the JUICE 2 report gave it. So the JUICE 1 report actually did not stress that the symptoms was a prerequisite of the diagnosis. But the JUICE 2 has included that as part of the diagnostic definition. I would agree. We do see some patients, especially if they've had, let's say, corneal laser surgery, who actually have a relatively anesthesized cornea, and so they're not going to experience the sensations of dryness that other patients would have. If we sometimes have a patient with really chronic dry eye, that sensation has become so normalized for them that in actual fact they don't present with this being a symptom that they have recently encountered. Preoperatively, the question asks about you screen patients and preoperatively they have dry eye. For sure. I work in a refractive surgery setting, and we deal a great deal with premium IOLs. And we know that the outcome of those IOLs is based on biometry. Without appropriate biometry and without a pre-operative evaluation of dry eye, we will be, in some situations, putting a lens into an eye which might maybe 0.75 diopters out, just purely because of the blinks, between the blinks, this instability will give us that error range. So it is imperative, and I think this is what's created a lot more interest about dry eye, is the fact that the American Academy has said that really it's best practice to evaluate dry eye before any cataract surgery or any intraocular lens surgery. So, and I would concur with that. Our outcomes from intraocular lens surgery and from refractive surgery have been very much enhanced very much better if we take seriously dry eye conditions and do this routinely on these patients. If we don't, then we're going to have those refractive surprises. In actual fact, they're not a refractive surprise. We've just not appropriately addressed some of the preoperative conditions that we should have seen. And those refractive surprises become very much less if we do analyze patients, even if they are symptom-free. Another question here is, symptoms may be reduced VA or change in corneal topography, which may not be noticed by the patient. So that's from Kevin Woodward. Exactly. I think you're right on page here. We're actually looking at dry eye being part and parcel of quality of vision as well as comfort. So without a very smooth, intact front surface, that front surface of the eye is not in actual fact the cornea, but it's more the stability of the tears. The curvature of the tears and the stability of the tears will define the quality of vision and the stability of that vision. If you're like me, we know that if we've been staring at a screen, and I'm going to be staring at this screen for around about an hour and a half, we don't blink as much. And if our tear film is not replenished, then we sometimes feel not only a bit of grittiness, but the quality of vision diminishes. So visual quality, not just visual acuity, but things like point spread function when we evaluate that. By treating dry eye, we can actually improve quality of vision, and that quality of vision either in recordable VA, contrast sensitivity, or distortions can be improved very much more by looking seriously at an ocular surface protocol for many of our patients. So yes, it's not dependent on symptoms, and it's not just dependent on the irritation symptoms, it's also to do with the quality of vision, so visual acuity. Another question that come in here from Eduardo Rez is IDRA equipment providing an ocular surface staining test? How, ? Or do you use fluorescein staining at the end of the test to avoid potential interference with the rest of the studies and methods? For me, it's something that I do as the last, pretty much as the last of all the tests, is to instill fluorescein. So a lot of my patient flow is to go and see a technician first to undertake the IDRA, which is a non-invasive test, and then come through, I'll examine the eye and then instill fluorescein at the end and take an image there. What IDRA does allow us to do is to evaluate the fluorescein stain if you are to use it as a digital imaging technology. So it does have a filter there that gives the corneal staining, fluorescein staining, that is evident. You can take an image from that and evaluate that and grade it accordingly. Images tell a lot more than just simply a simple numeric grading evaluation. So it's always nice to have a digital image, if possible, stored on a patient file so that you can compare one to the other. And also the location of the tear breakup time is available if you look with the IDRA device. So in some ways it will replace or could replace a slit lamp examination for some people. For me, it won't, because the optical quality is not as good and we're not looking at optical sections, etc. But we can do a fluorescein test within the IDRA and an imaging there. We can ask Simone at the end as well in terms of anything that may be coming along the way in terms of an automated evaluation of the tear film from a fluorescein point of view. But I see it as part of the professional, the clinical evaluation that I'm seeing when I'm looking on a slit lamp. Okay, so Simone will actually answer some of that question as well, more towards the end. We'll not get him on the webinar quite yet because we'll never get rid of him. So, oh, sorry, Simone, apologize for that. He will be along later. Let's just go back one slide here. I did leave it at what is one of the crucial points for me, and what has changed over the course of the last year or two in terms of what's new and what are the techniques we can offer which are quite specialized and give us some of the critical features of what a dry eye condition is and the differential diagnosis. So we understand that the majority of patients have an evaporative component to their dry eyes. And evaporative means that the lipid layer, typically at the anterior surface of the tear film, is disrupted, and that allows the aqueous, the water from within the tears, to evaporate. And this is how I explain it to patients. If the water evaporates, the salt concentration builds up, and we can get further damage. But we've got to look at that primary barrier, that first barrier to evaporation of the tears, being the lipids, the oils. And the oils we know come from the meibomian glands. Okay. And within the JUICE 2, it talks about a meibomian gland disease assessment as being mild, moderate, or severe. We want to get as much information as possible, not just in terms of the meibomian glands, but also the quality and the quantity of the oils that are there on that surface of the tears that stops that evaporative process. So we can see here the SBM and device the IDRA offers us an evaluation here on the left, which is interferometry, and also a way of using infrared technology to analyze the structure and anatomical features of the meibomian glands. Eversion of the lids with the IDRA allows us a way of imaging that. But let's look at that tear layer to begin with. So how can we analyze tears, or the lipid within the tears? Well, if you've ever walked down a street and there's been a little bit of oil or petrol on the surface of a little pond or something of this nature, or a puddle, you can sometimes see those color fringes, those changes in refractive properties of the surface. And we can see this as a dynamic. We've seen this in general purpose, but in actual fact, by creating an algorithm that can analyze this tear film component by looking at the color fringes, it gives us an indication of the thickness of the lipids on the front surface of the tears. So we can see here these nice colorations, and we can also see as the blink occurs, the change associated with those lipid layers. Okay, and what we have is an ability of evaluating that thickness and saying whether or not it is very thin or whether it is a normal tear film. So on the left here, you can see that we have on the grading scale, the traffic light system, we have the pointer looking at just within the red. Okay. Here we have it on the green, so the green is okay. The left is suggestive that there's a lipid deficiency within this system. Okay. Patients like that. So we can look at this and we can evaluate it. Historically, and with some of the systems available, and some of the systems such as the OSA, if you have that, we would previously use the image and compare it with a grading scale to give us an evaluation of the components of the quality of the lipids or the thickness of the lipids. But over the last year or so, we've seen a fully automatic method of doing this, where the algorithms have been calculated to enable us to give an evaluation in terms of microns of lipid thickness on the cornea. So this is an image which is suggesting that there's a fully automated interferometry within the IDRA device. We can see the images over here. This is actually an image telling a patient of the front surface where the lipids are. So it's an instructional point of view from the software that helps describe the condition to the patient. And then we also have the traffic light system. Along the bottom here, we can see that it's been measured over the course of 3 different blinks. And an average can be shown, or an ultimate level can be chosen from a still. But in here, an average would give us a green on the grading scale here. We can see a numeric value assigned to this. And so anything of 100 microns or above would be normal. Anything below 50 to 60 microns is abnormal, and we have that gray area between, or not so much gray, it's an amber area where it's borderline. And we can look at this, and we can see that in actual fact it varies, and it will vary from patient to patient depending on the degree of lipid production. Sometimes we can find a patient that has very pronounced lipids, and that can be sometimes because of an abnormal rubbing of the eyes, or having put drops in the eyes before. So with all these tests, we have a regulation in terms of not putting drops in for at least half an hour before the examination. In actual fact, we recommend with some of our chronic long-term patients to have the non-installation of drops for anything up to 2 hours and record that accordingly. But it's important here, if I stress the fact that it's automated, and I stress that because it does allow a technician to do some of these tests. It means that it's reproducible in terms of the test, and so that before any treatment paradigm is introduced, we have a baseline. And we're not using subjective or operator variability here. We're having an objective automated method, which means that reproducibility of evaluation of this is improved. It is a feature of the new IDRA device that I'm not sure is currently available with some of the other technologies. In actual fact, I think there's only 2 companies in the world that does have interferometry as a test platform, and certainly from my point of view, the IDRA offers a very reproducible way and a more automated way of evaluating this, one of the most important diagnostic features of dry eye conditions. Let's come on to meibomian gland, or meibomian gland dysfunction. Here we're looking really at the quality and the anatomy of the meibomian glands. We can see here just by simply rotating the bottom lid, and this could be done on the upper lid as well. We can look with an infrared light at the nature of the meibomian glands. And we have this image here, and it can be highlighted, and again, really clever software analysis of this image will allow us to have an automated system of evaluating the percentage dropout of the meibomian glands. This image is a really nice image here, which shows some convolution, the very convoluted nature of the meibomian glands. So it's there, and it gives us an automated analysis being a 24% loss. Actually, patients like this numeric value, and it helps us in terms of treatments, because if we have a patient who has a meibomian gland loss, let's say of 50%, which can happen, and only have mild symptoms, to try and create a situation where we improve the functioning of the existing meibomian glands and help to protect those, the patient will be far more likely to comply. So that might be as simple a technique as lid margin hygiene in a patient with blepharitis. We can show them blepharitis, and we can show them the impact that potentially this is having, and some of the necrotic issues that can be associated with that at the exit of the glands, and therefore the glands are dropping out. So this is probably, from my patient's point of view, is something that they are really keen to see, and they're very happy to have this monitored and trying to understand the fact that actually the 25, or in this case 24% of gland loss cannot be resurrected. We cannot get those glands back. But what we should be doing is do everything we can to maintain the health of the rest of the meibomian glands, and that will hopefully reduce the natural apoptotic response that we will get with age. So it's important. And again, it is fully automatic, so it is far more reproducible than any other way. And these images can be stored. It's fully automated, and it gives us this evaluation of the meibomian gland loss that is currently exhibited by a patient. So drawing back to the 80% of patients that have a component which is evaporative, abnormal lipids and meibomian gland disease is something that we should be looking at. The SBM provides us with this. We can see that the fringing here, the interferometry is evaluated, and we can look at the meibomian gland structure here, upper and lower lids, simply with a straightforward lid eversion. So that really gives us what JUICE-2 says we should be doing. We should be looking at evaporative, and so is meibomian glands and interferometry. There is a lower limb here, which is less common, but can be some of the more severe patients. And the patients with very severe symptoms can be those with aqueous deficiency. Things such as autoimmune conditions, which we encounter Sjogren's being the one that comes up to the fore very often. It's something that has a great deal of interest to me, and we're associated with the Sjogren's Society here in the UK. So it's a matter of looking at patients with aqueous deficient. What this means is the low tear volume. In some ways, the lacrimal gland has been damaged or is not functioning appropriately, and we're not getting the cushioning, the bulk of the tears, which is that cushioning in the aqueous, and we will find that patients get quite severe dry eye symptoms, and also the breakup of the corneal surface impacts on the health of the cornea and conjunctiva as well. JUICE-2 says tear meniscus height of 0.2, 0.1, or 0.0, meaning no tears, will give an evaluation of mild, moderate, and severe. But let's have a look at that in a little bit more detail, and how can we evaluate that? So the IDRA device measures the tear meniscus height, and it allows us to measure not only just one location, but multiple locations along the lower lid. We're looking at the image of the tear meniscus, that tear prism, and if the height is greater, that's suggesting that there is fluid within the tears and the volume is greater. It's that reservoir of tears that we get collecting at the bottom, along the bottom lid. It will also give us an indication if a patient has some abnormal anatomical features of the lower lid. We can measure it at different locations along the lower lid, and that can give a differential diagnosis of a watery eye. Is that watering coming because we have some relaxation of the lid margins, or is it the puncture is blocked? The dynamics of the tear flow over that area and the volume will give us an indication there. So what this offers is a way of evaluating both right and left eye, evaluating and calculating the tear meniscus height. And in this case, I think it says 0.12, and along the lines of the definition within most of the studies is suggesting that this is an abnormal test, an abnormal outcome, and the severity is there. But it gives us a metric. In actual fact, around the world, some people have various ways of analyzing what is normal. So in some parts of the world, a tear breakup time of 6 seconds may be deemed normal. We tend to use in the Western world 10 seconds, but we can actually change the metrics here and give a differential evaluation in terms of what's normal, abnormal, depending on your view of the diagnostic features of dry eye. I've been talking a great deal about JUICE-2, and I said earlier that I may share most of the opinions with JUICE-2, but we all have our own professional judgment. So whilst a tool such as IDRA provides us with the metrics, we also have that professional judgment in terms of what is the condition, and it being a multifactorial condition, part of the components that you may feel relevant may not be within this JUICE-2 protocol. And so for this point of view, there is more than just that JUICE-2 protocol. We do need to look at things such as conjunctival redness, and we can image the conjunctiva here. In some patients, we will also find that we would like to image that and quantify that. And I believe the software, if it's not currently there at the moment, may well be with us to analyze that degree of conjunctival redness as well. We can look again at the lids and the lid margins and take an image here to best describe things such as Demodex blepharitis to our patients. Some of those difficult conversations we have with our patients are very much supported by images. So the IDRA will provide us with a really good quality image there that can help that discussion process. And I mentioned earlier about the blink dynamics. The frequency of the blink and whether those blinks are complete or incomplete is another feature that we can have within the IDRA that gives us part of the diagnostic features beyond those that are deemed to be normal within the JUICE-2. So we're moving forward even from JUICE-2 to what else is happening, what other techniques are there, and is there a way of better diagnosing various dry eye conditions. This is an illustration of a diagram from one of my friends and a dry eye specialist, an ophthalmologist, Luca Vigo's paper, I think it's from last year, which looked at using not just one metric to diagnose dry eye, but also a series of metrics. So looking at lipid layer thickness, non-invasive tear breakup time, meibomian glands, and tear osmolarity, and bringing those four features together improves the sensitivity and specificity to that diagnosis of meibomian gland dysfunction or an evaporative dry eye. So the more features we have, the more secure we are in those diagnoses. IDRA is great for this. In actual fact, they have a control panel which gives a definition of each of the different components of the examination. I'd like them to actually turn it around and call it a dashboard or an autopilot, just because it would be great with my surname being Dash, but it's something we call in the practice is a dashboard. But this is a very normal feature. I've stressed to you before that it's important to communicate effectively with patients, and if the patients understand that you're taking this seriously, then they're going to be on board. They're going to talk to other people, so may go out for a beer and talk about it. They may go out for a cup of tea and talk about it here in the UK. But to actually give them not only the information in their brain, but actually to give them a report can sometimes be of great benefit. Here we can see a whole list of an examination report that can be customized within the IDRA platform, which will use the grading, the traffic light system to inform a patient, or in actual fact, sometimes one of our fellow colleagues, let's say a dermatologist, because we get a lot of referrals from dermatologists because some patients with dermatological problems are predisposed to ocular surface disease. So it's a matter of saying, all right, well, if there's a dermatologist that is involved in treating a patient for acne rosacea, and this is then they prescribed Roaccutane, and the Roaccutane has caused a dry eye because it's suppressed the production of glands, then the fact that we are providing the patient and the dermatologist with this other information we're getting a lot of referrals, not only from the patients referring their friends, but also the dermatologists referring patients. If we have a rheumatology patient, a patient who has Sjogren's or SLE and has a dry eye, then by providing that multidisciplinary team that's looking after the patient with the information, they are sure that we are being ultimately diligent and really a center of excellence when it comes to dry eye, which is a component of many systemic conditions and treatments. So this is something that I'm really happy with. It's something that we can provide patients with a PDF, so it doesn't have to be a physical printout. It's something that they can have on their mobile phone. After all, let's use the device that is causing some of this dry eye. If we can use the mobile phone to solve some of the problems that it's causing, then I think we're doing a good job. So offering a PDF to enable a patient to monitor, but also to inform other people of the condition of their eyes, and that's really important. The one feature they do like, and they always want to view, is the meibomian glands. So it's easy to understand that structure. There's a structural deficit, then it's easy to understand why there's a problem. It's a little bit easier as well if we're doing something sexy with a three-dimensional image and a moving image, and that provides us with a big wow factor. So that wow factor is what we want to enable us to grow our practice and best serve our patients. I'm going to take just a little bit of a break here just for a couple of more questions. How do you manage aqueous deficient dry eye? Well, the most standard way of undertaking a management of aqueous deficient is to try and stop the outflow. So if there is some production, we slow the outflow with the punctal plug, then that may well help. And very often we'll do the uppers and as well as the lower puncta here. In fact, we start with the uppers and usually, and then may go to the lower puncta, and we find that patients with the reduced outflow will retain more of the aqueous, and therefore they will that will overcome some of the symptoms. Other things you can do is, if there is a little bit of secretion in the lacrimal gland, we can stimulate the lacrimal gland. There's some little nasal stimulators you may be aware about. Sticking something up your nose that creates a natural tearing process will work really partially, but it's only a transient benefit. One of the things that I do in Sjogren's patients is actually to fit a scleral contact lens. So the scleral contact lens will trap behind the lens and on the corneal surface and the conjunctival surface. It will trap an environment of saline, and we actually sometimes enhance that by using various tonicities and various lubricative agents such as HA, hyaluronic acid, within that environment to stabilize that. It is important in that case, obviously, to remove any preservatives that are within that drop that you may be using upon installation of this scleral contact lens. But I'm a great advocate for scleral contact lenses. I think I mentioned earlier that how it has an impact, how big an impact it has. Some dry eye patients. I have a patient to mind now who used to come into the clinic, and she would always ask me to turn the lights off and the air conditioning off. And I knew that when I saw her on the list that I had to do that before she came in, and she wore vapor controlling eyewear, and it had destroyed her life and her family's life because she wouldn't go out. She needed caring for, and she was depressed. And we tried everything. We even tried IPL to stimulate the meibomian glands to try and produce a little bit of lubrication there. But in the end, last year, I did a very quick trial with a scleral contact lens, and she did very well with that. And my commitment to her was to actually find I said 8 hours on Christmas Day that I would get her to a situation where she could be with the family and do normal things. And I was lucky enough to achieve that just by her wearing a scleral contact lens part-time in the morning, so 3 to 4 hours in the morning, 3 to 4 hours in the afternoon. And that gave her very significant relief. And she does go out now on her own. She feels comfortable in the car when she's traveling. So it has been a game changer for her. But that was a scleral contact lens and uses some of my optometric background together with dry eye disease. So that's how I deal with aqueous deficient patients. One other question related to this from Ronald is, do you believe that punctal plugs increase the inflammatory cascades? The answer to that, and I'm actually an immunologist as well. So my primary degree was in immunology and cell biology. So I'm very interested in the inflammatory cascades and the inflammatory association with dry eye. There is no simple answer to this. As we see in a dry eye situations, it's multifactorial. So if the dryness of the eye, if we have punctal plugs that actually retain more lubrication on the eyes, and therefore we're going to reduce the physical trauma associated with the dry eye, then we can reduce the inflammatory cascades. So that is possible, but there are simply also the possibility of increasing the inflammatory cascades if we have a complete blocking of the puncta and we're getting necrotic buildup. So we're getting cells and necrosis and debris within the tear film that sets up those inflammatory responses. We're also mindful of, depending on the nature of the material of the punctal plug, it's within the lid margins, and that could cause an inflammatory response there. So there's no simple answer there. Do punctal plugs increase the inflammatory cascades? Yes, in some patients, but it can also reduce them in others. It depends on that individual. And we do know that it does increase the risk of conjunctivitis by reducing the outflow. We've got to remember that that flow of tears is there for a reason, and that is to flush away any debris that may be within the tears, any antigens that exist in that environment as well. Inflammation in terms of its role within dry eye is something that we do look at, and we do use an MMP9 marker, which is metallic, it is a way of recognizing if there's any inflammatory cascades associated with the dry eye. And if that is the case, then we will go down the use of some steroids or non-steroidal anti-inflammatories as well. So, as I said, this is a multifactorial condition. Each patient will be different, and we need all the diagnostic tools we have available to us to enable us to target the most effective treatment paradigm for those patients. So thank you for that, and keep the if you can keep the questions coming, I'm more than happy to answer those questions. So what does a dry eye practice look like to me? Well, it is based around the IDRA device, and I'll share with you just one patient, and it's this is a patient who has, when we look at the tear meniscus height, they're borderline. So they don't have great quantity of tears in the eyes. We have a tear breakup time, which is I think that's 6.2 on 6.6 seconds. So there is a breakup time that is which is abnormal. So we have borderline to abnormal tear breakup, non-invasive tear breakup time. We have meibomium glands that are in the green, really good quality structure of the meibomium glands. But actually, when we look at the whole report, there's one area here that stands out to be in the red, and that is to the lipid layer type. So here we have around about 15 microns of tear meniscus height, which is abnormal. So this is pointing to the fact that the patient has an OSDI, has symptoms which are significant to severe, and we have a very reduced layer of lipids on the eyes. So in this case, we need to improve the lipids, and we look at a tailored program to enable us to treat the underlying condition. So I have a mantra which is vision without action is a dream. Okay, so if we have all the diagnosis, but we don't do anything about it, well, we may as well be dreaming. Action without vision is aimless. So if we just throw drops at something and we have a go-to dry eye drop, but we don't know what the underlying problem is, usually we're missing the target. However, if we have vision, we have proper diagnosis with a targeted treatment, that can be really meaningful for patients, and it's a meaningful innovation. Here we have something that is really interesting, which is a phone a friend type of scenario. Within the program at the IDRA, it gives us an option of a suggested treatment plan for a given diagnostic feature. And so what we can do is we can use this as a way of suggesting and supporting some of the decisions we make as a clinician. And we can tailor this. We can say that a certain drop would be needed. Let's say we agree that because there's a lipid insufficiency, we want to increase the dietary intake of omega-3s, especially if a patient has poor diet. Then we might say that is that. And you might choose a specific brand of nutrition. And so we could actually put that in the software. If not, there is also a supporting software, so a treatment paradigm and algorithm that is created based on a third-party ophthalmologist. Again, this is Luca Vigo in Milan, who has agreed to share his protocols with regard to treatment. And this helps in some ways supporting a treatment plan for the patient. In this case, it might be lipids, it may be the use of IPL, which is, I'm an advocate of IPL being a great benefit in terms of improving the quality of the lipids and resetting that function of the meibomian glands. Although I'm not convinced I know exactly why it works, it's something that I know works, and the reason being that all the subjective and objective results we get for patients that undertake the IPL show that improvement. So it's not just based on a patient saying their eyes are better, but we're getting objective ways of validating a treatment paradigm such as IPL, and this further reinforces the benefit to patients. Okay, so I'm going to leave just a couple of these questions. No, I won't. I'll go on to one here, which is from Eduardo. In the case of an eventual inflammatory response due to punctal plugs blocking fully, would it be better to use perforated punctal plugs, flow control plugs then? Do you recommend it in most? Yes is the answer to that. I use both the control flow plugs, and also I will often use as the first plug a temporary plug that is there, and it's an absorbable plug, so it doesn't always remain within the eye, and if a patient is lost to follow-up, I've not left a little bit of silicone or plastic in the eye. These will absorb. So my first point of call may well be either a flow control plug or a absorbable plug with a view to long-term permanent plugging if that's necessary. Francis Roy, in the era of social how easy is it to fit plexiglass shields between patients and an examiner? Okay, so this is social distancing. How do we do that? Yes, certainly within the clinic, and I've been isolated now, so I'm not in the clinic. Within a clinic setting, we've fitted a natural screening mechanism. It's a simple plastic screen that we have between myself as a clinician and also the patient. This is something we do on a slit lamp where we're getting somewhat closer because we're looking at an eyepiece. With the IDRA, it's not something that we've encountered, but you can see from the image here, we're looking at a computer screen by the side. So there is a natural distancing, but any PPE that exists, then I think we should be using that whilst the COVID-19 is in existence. So this may be face masks, shields, etc. So the appropriate level of PPE would be necessary. I'm not an expert on that, and we've actually had our clinic closed and taken over by the National Health Service because we have an operating theatre which can be used as an isolation facility. So thank you for that question. I'm going to leave you with just a couple of the highlights here for me, which is some of the game changers in the last year or two, which is automated data analysis and data collection. So most importantly, interferometry and mybography. It's great to have that numeric value, which is automated and reproducible, independent of the technicians that's undertaking it or evaluating it and cross-evaluating it to grading scales. The tear meniscus height gives us great indication in terms of that aqueous deficient patients. But perhaps the biggest thing is all this sexy technology is great in terms of acquisition of information, but it's actually disseminating that information. Giving patients the information helps drive patients in. Sharing this information with colleagues, either other optometrists or ophthalmologists, but also it can be, as I said earlier, a dermatologist, it can be a rheumatologist, it can be a diabetologist, it can be glaucoma specialists. Within the clinic, we have a glaucoma specialist, and the incidence of dry eye with glaucoma is very great. And therefore, yeah, it's dry eye, and the IDRA is something that not only markets itself to patients, but markets to our colleagues, and we get referrals from that. The millionaire slide at the bottom here just relates to the fact that we have the option of the phone a friend. So within the software, that phone a friend is you can have that treatment plan of Luca Vigas that is there to support your decision, maybe help you make the decision, but more importantly, really to support some of that patients if they see that this is a recommended treatment given by a fellow clinician that has no vested interest in gaining income from that diagnosis, then they're far more likely to undertake that procedure. So for me, I am a clinician, but I also have to make things work in a clinic setting, and financial things are there. So whilst I use the anachronism ATM, dry eye being an ATM, I'm not saying that it's as easy as getting money out of an ATM machine, but it certainly does generate sufficient income to the practice as a standalone tool. But it also supports things such as intraocular lens surgery and the upgrading into premium IOLs. Our confidence level is very much greater if we have a good ocular surface. Our biometry is better, the recovery from surgery is quicker, and the outcomes are better, and, and patients typically happier. Anything to do with corneal surgery, for sure, we need to make sure that the very front surface of the visual system, so that change in the light from the air through to an ocular surface, that change in refractive index is greatest at the very front surface of the tears. It's not the cornea itself. So we need to have a very good ocular surface to give us good healing, but also good quality vision. And contact lenses induce dry eye, as do various medications. And so who and where and when do we use a dry eye diagnostic technique? Well, it depends on you as a clinician to make those calls. Any patient with symptoms, for sure. Any patients undertaking intraocular surgery, for sure. Any new patients with regard to contact lenses or refits of contact lenses or non-tolerance of contact lenses, for sure, we should be looking at, instead of changing the type of contact lens, but we should be treating the primary cause of some of the dropout, of patients from contact lens by looking at dry eye in a serious way and targeting that as and when we fit and refit the lenses. So that's effectively what dry eye is to me, and I'd like to thank you for listening to me for the last hour and 10 minutes or so, and I'm more than happy to stay and answer any questions. I would also like to share with you a little bit of a video here, which is just a video that we can perhaps play in the background. I'm not sure if Simone can actually